So I want to check that the microphone is working, and it is. Good afternoon, good evening, everybody. My name is Bernard Prendergast, and I've been given the significant challenge of delivering this session at the end of a very busy day, in which we will incorporate two breaking innovative technologies supported by Edwards Life Sciences, using two live cases with two lectures, two spokespersons, two sets of live case operators, and 8 panelists, one of whom is Giuseppe Tarantini. It is going to be a significant challenge. But on that note, I want you to engage with us in an interactive way, because we have a lot to cram in the next 90 minutes, as you will appreciate. So if there are questions, you can deliver them to us via the app. I think we have some microphones in the corridors, and you can but please keep your questions short, and please keep your answers short as well, so that we respect the time limits. So in terms of the layout, we have here my conflicts of interest, which are limited. We have some stated learning objectives in which we want to learn more about the SAPIEN 3 Ultra RESILIA valve and the EVOQUE Tricuspid valve and the advantages that they offer to patients. And we have a distinguished team you see here assembled. I'm not going to list them in order, but I just want to outline the session, in which part 1 will focus on aortic valve intervention, namely with the RESILIA valve. We will have 2 short lectures from colleagues who already have experience with this device in other geographies. We will then link to a live case from Spain and finish at 45 minutes. We will then transition to tricuspid valve intervention with a live case from an alternative center in Mainz, Germany, where they've already been busy transmitting cases to the main arena today, earlier this morning. So that is the outline of the program that you see in front of you. And without further ado, I think we should step immediately to the first speaker, who is Rahul Sharma from US, who has had his hands on the RESILIA valve for some time. Rahul.
Thank you, Bernard. So it's a great pleasure for me to discuss the first of the technological innovations we're discussing here today, and that is the SAPIEN 3 Ultra RESILIA platform, and I'll be sharing the perspective from the United States, while my colleague Dr. Hayashida will share the Japanese experience. So the SAPIEN 3 Ultra RESILIA platform is really built on a legacy of innovation from the Edwards Life Sciences family. And a lot of us here are familiar with that technological journey, starting with SAPIEN, then moving to SAPIEN XT, then the SAPIEN 3, and then the SAPIEN 3 Ultra. And the SAPIEN 3 Ultra RESILIA is really built on this legacy and the understandings and innovations that have occurred with each of these iterations. And with the advancements in technology, so too has the expanded patient population changed over time, moving from patients who are inoperable, then to high risk, then intermediate risk, and then to low risk. Now, the PARTNER 3 trial really set a very high standard, and we saw that data presented last year in terms of 5-year outcomes. In terms of all-cause death, you can see there excellent outcomes with the SAPIEN 3 Ultra device in terms of all-cause death. And then in terms of biprosthetic valve dysfunction to 5 years, as defined by the VARC3 criteria, something that's been of great interest, particularly of late. Again, you can see there excellent rates of valve performance in terms of all causes of failure, in terms of irreversible stage 3 dysfunction, the need for aortic valve reintervention, which of course is the most important for these patients, and then valve-related death. So what's different about the SAPIEN 3 RESILIA platform? This idea of advanced calcium blocking technology, it's similar to what our surgical colleagues have been using for some years in the Inspiris RESILIA surgical valve, where we have a significant amount of data as to the benefit of the RESILIA tissue. And it's the only THV that's commercially approved at the moment that allows dry tissue storage. There's an enhanced PVL outer skirt now for all the valve sizes across the range, now including the 29mm device. We have real-world outcomes for the 5th generation balloon expandable transcatheter valve here in the United States. You can see they're published over 350,000 patients. You can see with the RESILIA compared to the SAPIEN 3 and SAPIEN 3 Ultra predecessor platforms, this was a propensity score matched cohort across both groups, and roughly 10,000 patients in both groups according to the type of valve. You can see here in hospital and 30-day outcomes in terms of all-cause death, cardiac death, stroke, the need for new pacemakers, the need for aortic valve reintervention, as I mentioned, very important to these patients, any readmission, life-threatening bleeding, and major vascular complications. What about rates of PVL? We know that PVL is still important, and we want to avoid and mitigate PVL as much as possible. And so here we see across all valve sizes, and particularly a statistically significant reduction in the 29mm valve here in terms of discharge PVL for the 29mm valve. You can see there the vast majority of these patients had none or mild PVL. When you look at the 30-day rates across all valve sizes, again, significant majority of these patients had none or mild PVL, so excellent performance in terms of PVL rates. Gradients are very important, and as I mentioned earlier, particularly generating a lot of conversation recently. And so these patients had significantly lower echo-derived mean gradients and larger EOAs across all RESILIA valve sizes. You can see here both compared the SAPIEN 3 and SAPIEN 3 Ultra, the predecessor platforms in blue, and then in red, the SAPIEN 3 Ultra RESILIA novel technology platform. And you can see the discharge mean gradients on the left and the discharge EOAs there with an improvement in terms of the RESILIA platform. So in conclusion, the partner trial demonstrated excellent outcomes and low intervention rates with the SAPIEN 3 TAVR. The SAPIEN 3 Ultra RESILIA improved further upon these, incorporating the RESILIA tissue to address calcium, which remains the leading cause of valve failure and therefore a big component of lifetime management of these patients. In a large US real-world performance dataset, the SAPIEN 3 Ultra RESILIA demonstrated outcomes consistent with what we saw in SAPIEN 3 and Ultra Valve in terms of excellent performance, statistically less paravalvular leak, including the larger 29mm valve, and very importantly, statistically lower echo-derived gradients and EOAs across all valve sizes. Thank you.
So thank you, Rahul, and thank you for being so on time. And we're going to go directly to Kentaro and hear about an experience with the same device, but from the other side of the world in Japan. Thank you, Kentaro.
Thank you very much, Bernard. So today I'm going to talk about the initial experience of SAPIEN 3 Ultra RESILIA in Japan. Actually, we are organized Ocean SCT family, which includes TAVI, mitral tear, tricuspid, and appendage closure. And we have enrolled more than 22,000 TAVIs until the end of the last year. And it consists of the 29 very high motivated, high volume center. And 1 year follow-up was achieved in 99% of the patient. And we are quite happy to launch SAPIEN 3 Ultra RESILIA in the last year, March. And we have already experienced more than 1 year experience. And we compare our initial data comparing SAPIEN 3 Ultra RESILIA and SAPIEN 3, because we jumped from SAPIEN 3 to Ultra RESILIA. And we performed propensity matched cohort. And we compared the 600 SAPIEN 3 Ultra RESILIA and 600 SAPIEN 3. And amazingly, if we look at the data, severe prosthesis patient mismatch was noted in only 0.5% of the patient with SAPIEN 3 Ultra RESILIA, and significantly reduced compared to that of the SAPIEN 3, especially in a cohort with quite small aortic annulus in our cohort. And PVL was dramatically reduced by SAPIEN 3 Ultra RESILIA from 1.1% to 13%. And the mean pressure gradient was dramatically reduced from the 6% to 1.6%. That means the SAPIEN 3 Ultra RESILIA provides much better hemodynamic performance over SAPIEN 3, especially not only in large annulus, but also in the very small annulus. And if you look at the data about the effective orifice area, and SAPIEN 3 Ultra RESILIA provides much larger effective orifice area compared to that of SAPIEN 3. And the mean pressure gradient of the overall cohort is only 9 mm mercury, even in the patient cohort with quite small aortic annulus. And this is a subgroup analysis. And even with the 20 millimeter SAPIEN 3 Ultra RESILIA, Moderate ppm was noted in only 8%. That is quite similar to the percentage of the moderate ppm incidence of SAPIEN 3. And amazingly, we didn't find any severe prosthesis patient mismatch in the 20 millimeter SAPIEN 3 Ultra RESILIA. That is significantly lower than that of SAPIEN 3. In conclusion, ladies and gentlemen, SAPIEN 3 Ultra RESILIA was associated with much better hemodynamic performance compared to SAPIEN 3 in all size variation. And notably, the severe prosthesis mismatch was noted in only 0 and 0.9% with 20 and 23 millimeter SAPIEN 3 Ultra RESILIA respectively. And the PBA was significantly reduced with SAPIEN 3 Ultra RESILIA compared to SAPIEN 3. And in conclusion, SAPIEN 3 Ultra RESILIA provides much better hemodynamic performance and reduced PBA over SAPIEN 3, even in patients with quite small aortic annulus. Thank you very much.
So thank you, Kentaro. These data are very impressive and particularly reassuring in relation to the small annulus and the small body size of Japanese patients. And if we can extrapolate that to smaller patients across the world, we can be very confident about this platform and what it may promise for long-term outcomes. I have just one very quick practical question. The dry prep of the RESILIA valve is potentially an advantage for storage and for rapid turnover of cases. Did that make a difference in your practice in Japan?
Thank you very much. Actually, we don't need to take time for the preparation of SAPIEN 3. Before that, we needed to rinse the valve, but after introduction, the SAPIEN 3 Ultra RESILIA is quite much quicker, so that makes sense. Yeah.
And ergonomics all round. Okay, well, thank you, Kentaro. We're going to move on now. We have to maintain this rapid momentum. So I'm now turning to Michael Jonah, who's going to tell us about the first live case, which will be coming to us from Spain. Michael, the floor is yours.
Thank you, Bernard. Ladies and gentlemen, it's a privilege to present the first patient that we discussed tonight. This is my conflict of interest. So our patient today is a 77-year-old woman. She presents with a BMI of 24.9. She has very little cardiovascular risk factors, dyslipidemia, no other cardiovascular background. In regards to her clinical presentation, she has dyspnea, NYH class 3, and she didn't have any sort of syncope or angina before. When you look at her treatment, you can see she's on secondary prevention drugs, simvastatin, ezetimibe, omeprazole, and with regards to her blood work, she has a hemoglobin of 14.4, an NT-proBNP of approximately 1700, and a normal kidney function with an eGFR of 70-80 milliliters per minute. Now, when we look at her ECG, she has sinus rhythm, normal PR interval, and no AV conduction disturbances. On the right panel, you see her echocardiographic workup, which shows us severe aortic stenosis with a max gradient over the aortic valve of 88 millimeters of mercury and a mean gradient of 53, corresponding to an aortic valve area of 0.56 square centimeters. She has normal LV function, normal RV function, and she has no other significant valvulopathies. Now, a coronary workup was done also. The angiogram shows you the 3 major epicardial vessels, and you can see no significant stenosis. Now let's get to the CT assessment, and this is very important now. On the left panel, you're looking at the unfast view at the site of the annulus, and you can see a type 1 bicuspid valve with a calcified raphe between the left and the right commissure. You can see that the aortic annulus measured at an area of 397 square millimeters at this site, a perimeter of 72.5 millimeters, and diameters of 18.5 times 26.1. Now, just a little bit below, the LVT measurements show an area of 320 square millimeters, a perimeter of 65, and diameters of 17 by 24.2. Now, you can see additional sinus of Valsalva measurements, 29, 30, and 33 at the commissures, and the ascending aorta is free of any aortopathy with a minimum diameter of 35 and a maximum diameter of 37. You can see, most importantly, the calcified raphe again. Valve calcification sums up with an Ergertzen score of approximately 3,000, which equals to moderate calcification. Now, with regards to the Bavard configuration, it is important to understand that this represents a flared type anatomy, which tells you that you should rather simulate the valve, and you can see this below. This is what the operators did. A circle siphoning method was used with a simulation of a 23 millimeter balloon expandable valve, and you can see this in order to make sure that the valve is fitting perfectly within the different anatomical positions. So with regards to the access side, you can see there's minimum amount of tortuosity and calcification. The arteries look rather clean. And you can see on the left panel, coronary arteries take off with 11.1 millimeters for the left main and 13.9 millimeters for the RCA. So to summarize this patient presentation, you can see this patient presents with a Euro score 1 of 5% and STS score of 2.17%. And you can see the life expectancy in Spain and Madrid. Obviously, Madrid is even slightly higher than Spain with 87 years. So this was discussed in the heart team and commonly decided to perform TAVI in this patient. Thank you very much.
So thank you so much, Michael. We have a time for a short heart team discussion about this patient before we transition to the lab. To remind you, 77 years of age with a bicuspid valve and living in Madrid, an anticipation that this patient will live for 10 more years. But we understand in different sectors of the world there may be different life expectancies, and it might be interesting to muse upon that a little. So Radek, if I could come to you. In Poland, is this patient very elderly? Do they qualify for a TAVI? Or is it a little bit more borderline with the surgeons having an interest?
Now, in our country and in our region, the patient would be qualified to TAVI. We would probably target that this intervention should be the only intervention with the longest durability of the procedure as possible. So, of course, our lifetime expectancy is about 5 years less. But this is why this treatment should be the final one and optimal one.
Okay. And we recognize that the particular association of bicuspid anatomy, often with very complex leaflet morphology, and importantly with disease of the ascending aorta, can be fundamental in the decision-making processes. Remember also that we'll be hearing the results of the Notion 2 trial on tomorrow, in fact, Wednesday, a study which enrolled younger patients with a designated bicuspid cohort. So those results will be very important in guiding our practice. Perhaps we should now come to anatomical selection. And Giuseppe, valve sizing in bicuspid valves is always a difficult topic. How would you approach this case?
Yes, it's not straightforward like the tricuspid valve, because you have to consider two virtual rings. One is the annulus, the other one is the raphe. In this case, the raphe is less restrictive compared to the annulus. And actually, based on the matrix, we stay in the gray zone. We can go with a 23 or 26, but I think that there is a general principle with the SAPIEN that is that stretched is better than bigger. So actually, I think 23 is the way to go. And the only thing is to measure the gradient after the implantation, because we need to keep in mind that also with the SAPIEN, we might need to optimize. And this is something that is wise to keep in mind.
So are you suggesting that we go with 23 nominal with the facility to overexpand if we're a bit unhappy with the hemodynamics? Is that the plan?
My plan in this case would be 23, 2+.
Okay, perfect. Raj, you've probably put in more SAPIENs than anyone else on the planet. Do you agree with that advice?
So, the calcification pattern is a little bit bothersome. There's calcified raphe, another paddle or perpendicular plate of calcium. And I think we should be a little bit conservative. So 23 is the right size, but I would pre-dilate and soften things up a little bit. And with the first inflation, I would actually leave a CC out, make sure that I'm not exceeding 6 atmospheres or 5 at the first go, and then hit it again so that we can actually expand and hopefully give the full volume.
And Rahul, do you think there's any issue with pacing risk here? It's quite complicated annular anatomy. there's LVOT calcium there as well?
Yeah, I think, typically, and I learnt TAVI from Raj, so, bicuspids I tend to deploy higher, and so I think when you are deploying a little bit higher, all the more reason for precision and keeping that pacing run, making sure you have good capture and ensuring that it's deployed precisely where you want it. And part of that reason, I think, is to optimize your hemodynamics, but also minimize the amount of your valve and balloon that are interacting with that LVOT calcium, which in this case is not terrible, but to your point, it is present.
And maybe final question, Kentaro, would you systematically predilate bicuspid valves before you implant?
Yes, we usually perform the pre-dilatation systematically for the patient with bicuspid to get some feeling about the sizing. And if the patient had really heavily calcified raphe, and we can take into account the information from the pre-dilatation to the implantation of SAPIEN 3 to underfill a little bit.
Okay, that's perfect. Thank you very much. So if we could cut to these slides now, and I'll just bring us up to speed before we go to the lab. So here are the objectives of the case that we've agreed. I don't need to read these for you. You understand those completely. But I know you will be interested in how the cath lab team are going to approach this case. So in the Spanish lab, they're going to go with ultrasound-guided femoral puncture with radial secondary access. They are using a cerebral protection device because of the bicuspid anatomy. You can debate that all evening if you wish. They have some pre-designated projections to guide the valve implantation. They're going to predilate with a 20 millimeter valve, and they're going to implant a 23 millimeter SAPIEN 3 Ultra RESILIA. And I hope we will have time to demonstrate the on-table invasive hemodynamic measurements and correlate those with on-table echocardiography. Here's the team that we're going to join, a team led by Luis Nombela Franco, but his assembled team in the Spanish cath lab. So without any further ado, we will transition directly to the live case procedure. And here we are. We're with you in Madrid.
Hello. Thank you very much for the presentation and welcome to Hospital Clínico San Carlos. We are using this novel technology of SAPIEN 3 Ultra RESILIA. And as you have seen, we have selected a 23 millimeters valve. We have already crossed the aortic valve. We have cerebral protection in the system, and we have the pigtail from the left radial artery, and we have the E-sheath plus in the right femoral artery for the valve implantation. So we are advancing now a non-compliant 20 millimeters balloon, and we are going to perform the balloon aortic valvuloplasty in this case. So, okay, marcapasos on, balón arriba, balón abajo, okay, marcapasos off. So if you have seen, we have pretty much good predilatation, and we are going to advance now the 23 millimeters SAPIEN 3 RESILIA valve.
We can show hemodynamics?
Yes, we have already measured the hemodynamics invasive and by echo, and in fact we have a very similar data. Maybe we can show the hemodynamics in the invasive, which was a mean gradient of 51, and also by echo we have a very similar data. I don't know if you can project also the echo.
So thank you, Louis. You see those hemodynamics very nicely. There's a bit of ventricular ectopy, but nevertheless it's very clear. And this is your gradient on table, correct? With echo.
Yeah. Do you see the echo also?
Yeah, we do. We see a Vmax of 466 millimeters per second.
Perfect. So we are going to advance now the...
But just while we're advancing and mounting the valve, Giuseppe, there was no aortography here at the time of the BAV, which some operators use as an extra means of assessing the sizing. Is that something you use routinely? Is it now a little bit out of date? What's your view?
You're referring to the balloon before.
The balloon before, yeah.
So actually, I think sometimes when you stay in the gray zone, we still use it because it's safe to do that, especially when you go with the balloon that is downsized like this. But what is interesting in this case is considering that the RAFE is towards the left main, there is a displacement of the balloon. We have a conduction disturbances even with a 20 millimeter balloon. This is the reason why we used to see a higher rate of pacemaker with a bicuspid valve.
Yeah.
This is interesting.
Yeah. And that's also why we've got a temporary wire in. I'm not sure whether the team are going to use direct LV pacing or pacing using the temporary wire. But anyway, we will allow them to concentrate on the delivery of the valve now without too much disturbance. So Louis, we're back to you, and you just work quietly and we won't distract you too much.
Okay, thank you. So we are using the temporary pacemaker, as you have also that, as you can see in the angio. And are you ready?
Yeah.
Okay. So
we already pulled back the balloon over the valve, and now we are flexing.
Try not to interfere with the cerebral protection device. And it's advancing quite easy. And this is our working view, which is the 3 coplanar view that we have extracted from the CT. And in many times, I have to say that here in this view for the bicuspid valve, we don't get a very aligned valve, so we don't see the radiolucent line, and we can see that, in fact, I'm going to do a fluoro just to show you that there is a lot of parallax in the valve. So we can perform, and we usually try to position the valve in this view, but then we change to another view. Can we go one time for the previous position, and we are going to do an injection here. Is this one?
It's looking nice. What do you think, Rahul?
I'd like to see an aortogram here in terms of position, but I agree that there is some parallax in the valve. But let's see what the aortogram looks like before making adjustments.
So this is the aortogram. As you can see, there is a lot of parallax.
And I think the right cusp
the
is a
central
bit deep
point
here.
is,
So
yeah, it's a bit deep, but probably when we adjust in the cast overlap view and modify to see the line, the light line, which correspond to the stent link fluoro angio. So here even there is a good demonstration that here it seems that it's a little bit high, I would say. Okay, in this projection. Sujétamela aquí.
Sí. Yeah.
Okay, we are going to do another angio.
Venga, ahora sí.
No, es que se está subiendo. Okay.
Dale.
Dame un test. Vale, un momentito. Voy a subir la fluoro y poner 10-20 allí. I think here is better. Can we check in the other projection, because we like to check in different projections. This is the coplanar view again, and we are going to do another angio. And here it seems that it's a little bit high, but I will go in this position, in this. ¿Implantamos aquí o en la otra? Yo prefiero la otra, ¿no?
Lo que quieras.
Sí.
Es que estás muy cómodo.
No, pero And we go. So we are going to... Esta de aquí.
Sí.
OAD, caudo 43.
Caudo 43.
OAD 11.
Louis, are you happy with the position?
We are happy, yeah. We are going to do another final angio here. Oh, one moment. No, I don't see very well the line.
Can I say something?
Can...
If you go in tricuspid a little bit more caudal, actually you will have the valve that is perfectly orthogonal, and it's easier because I think that cusp overlap is very difficult to apply when you have a bicuspid valve. So I prefer to go with a tricusp, a little bit caudal, and then you go because also the pressure is going down.
Okay, so we will go here. Marcapasos on. Inyección.
Inyecta.
Balón arriba.
Voy.
Se sube, vale. Sigue. 1, 2, 3. Marcapasos off.
So Raj, it's
Okay.
often difficult with this slightly bulbous bicuspid anatomy, isn't it, to see the plane of deployment. Do you have any additional tips you can offer?
Okay.
You know, I
maybe
think
we can
they did a pretty good job here. But in terms of positioning and what we will typically do is we go to the coplanar view and then we'll tweak it. Just go a little cranial, a little caudal to get rid of the
play a little bit on the
parallax, but
ankles,
not go in such different views. Then it becomes a little bit more confusing. You can also relax or give extra flexion, one or the other, to see if you can actually become a little bit more perpendicular so that you're not low on one side and high on the other. And I saw that you gave a nominal volume, huh?
Yes.
Yes. Okay. So we can.
But I think it's good
go,
position, though.
It looks like a nice position.
Yeah.
Louis,
I think it's
take
a
your
nice
time.
position,
If the
so we are
patient
going
is
to
a little bit
do
uncomfortable, don't worry. Just take your time and deal with things in the cath lab. We have loads to talk
so
about
now we
here.
are going to see the by echo. Edu, you can go and see.
No pises, Luis.
Maybe just be careful of screening your imaging specialist's hands.
Yeah. Go ahead.
Very good point.
We need to remain friends with the imaging specialists, you know?
Yes, of course.
No sé si...
Yeah. Okay. Okay, vale. Pigtail. So, Eduardo, is there any paravalvular leak or...
There is
gradient, of
nothing.
course?
I mean, the valve is well expanded and I cannot see any leak. I will measure the gradient right now.
Okay.
So
So
mean gradient is 5.
Louis, we're going to let you do your
position
measurements,
and
both invasive
function
and
is
non-invasive.
very good.
We're going to have a little bit of a conversation here while you just get the measurements in the cath lab. So, Michael, firstly, I want to ask you about what your thoughts are about the merits of invasive versus non-invasive hemodynamics, particularly in this setting with a patient lying flat on their back.
Yeah, you give me a difficult task before I can go over to the questions here. So I think this is a very important question, and it's very contemporary given the huge discussion about invasive and echo gradients. I think, you know, we've seen in most of these cases excellent invasive gradients when you perform simultaneous measurements in the left ventricle, and sometimes by echo you see slightly higher gradients, and that has related to the phenomena such as pressure recovery, etc. We know this. We've been knowing this since years, actually. So I think this is a perfect result what he showed just by echo, because it looked like this is very little gradient. So from invasive, this is just perfect. And in the future, I think we have to rely much more on invasive gradients.
Okay, and we have some questions from our audience. So please tell us what is the context, and we'll address it.
So the audience is interested in 2 points. One of that is related to the sizing of the pre-dilatation balloon, whether there is a difference between tricuspid and bicuspid valves. And the second question is related to the pre-TAVI workup, whether routine coronary angiography should still be performed.
Okay. So I think you told us, Kentaro, that you systematically predilate. Do you undersize the balloon, or do you use a nominal balloon?
I usually use the equipped balloon by Edwards because to get some impression in terms of the sizing. So if we can use the same size of balloon, we can feel the same impression. So I usually use the equipped balloon.
And just to complete the question, do you combine that with aortography just to confirm the sizing?
I used to do that, but because if the patient has really small sinus valsalva, it might lead to the aortic dissection. If the patient has very small sinus valsalva and the leaflet is so calcified, I wouldn't do that. But in case of the doubt of the sizing, I sometimes perform the simultaneous injection. We call that root shot.
Okay, thank you very much. And Radek, the question of routine preoperative coronary angiography, is this now still part of the workup in Poland?
No, it's not anymore. I think we are moving away from coronary angiography to qualifying the patients fully on ambulatory basis, meaning that we just assess the risk of coronary artery disease. Sometimes we refer those symptomatic with previous stent implantation. But all the rest undergoes CT angiography and echocardiography.
Okay. So this may be of particular relevance, of course, in this younger patient with the bicuspid valve, where surgery is still, certainly in Europe, on the table. So it may well be that an angiogram would not necessarily be part of the TAVI planning, but it may contribute to a wider heart team discussion about the mode of intervention. Raj, did you have a comment? You look as though you
No,
want
I
to say
just
something.
wanted to come back to the issue of hemodynamics here. And I think the hemodynamics for a 23 millimeter, they're excellent, as we saw. And I think it is important to stress that we've traditionally been very focused on annular and supraannular and the differences in hemodynamics. But I think the leaflet design is equally important. And I think we saw this in the Portico ID study, for example, where an intraannular self-expanding valve actually had hemodynamics that were as good because of the difference in leaflet design. And I think here as well in RESILIA, the differences in hemodynamics are because of the difference in the leaflet design, the way they are actually anchored to the frame. The tissue is thinner between the leaflets and the frame, so they can actually open a lot more. And of course, there may be differences related to the way the leaflets are actually preserved, that itself, because that is what might explain the differences that Rahul showed in the 26 and 29 millimeter valves.
Super. Wonderful comments, very insightful. So Louis, we're back to you. Just give us a summary of the invasive and non-invasive hemodynamics, please.
Okay, so maybe we can show you here are the invasive. As you see, we have a mean gradient of 5. Also, Dr. Eduardo has measured. You can see the echo. The echo is here, which is completely the same as we have a mean gradient also of 5 millimeters and a maximum gradient of 10. I'm going to do a pullback from the pigtail, from the left ventricle, and we are going to do the final angio. Can we see the live? Okay, so we are going to do the pullback, and as
stay with the hemodynamics, please.
The hemodynamics.
So we just caught the back end of the pullback. Wonderful.
Sorry.
We're
so
also noticing.
We can show you here in the polygraph.
That's okay. We see it and we believe you.
Yeah, and we are going to do the final angio to see how the valve also. We have it.
So that is a perfect result.
Yeah, it's like 95, 5 in the ventricle position, no 95%, 5%. We don't have AB block and we don't have paravalvular leak. And as you have seen, this in a small anatomy but complex with this calcified raphe, the 23 millimeters valve works very well.
So Louis, thank you very much. I have a final question for you. We can see that there is some QRS widening in this patient, no AV block. Will you keep the pacer in overnight? What will be your strategy for observation and discharge?
Yeah, well, we usually keep the In these cases, because the QRS has increased in more than 20 milliseconds, so probably we will keep the temporary pacemaker this night, and probably because of the position of the valve, probably will resolve in the following hours. And if everything resolves, we will send the patient to the ward. And if not, we will keep the patient in the CCU.
Okay. So I think we owe you in Madrid a round of applause from the Théâtre Bleu here in Paris. So I think you'll agree that was a very swift and skillful case performed by the team in Madrid. It was wonderful to see the new Ultra RESILIA valve in action. It convinces us, based upon the data from the US and from Japan, that this valve is working very well in reality. The hemodynamics were optimal. We had a very good conversation about the sizing algorithms, the pros and cons of pre-BAV with aortography, and importantly, we've got an excellent result for this patient. We hope, of course, that this will translate into long-term durability, and the proof of that particular pudding will be in the eating, and we shall see how things evolve over the next decade. So we're now going to transition to the AV valves and to the right side of the heart, and we're going to focus on tricuspid regurgitation and the use of the newly available EVOQUE transcatheter tricuspid valve replacement system. We don't have any preliminary lectures in this part of the session because the live case may take a little longer, as you will all appreciate. And the case is going to be presented by Jörg Hausleiter. Thank you, Jörg.
Yes, thank you very much, Bernard. It's a pleasure to be here and to present on behalf of the team of Mainz the patient which we're going to see today together with me. The imaging will be presented by Isabel Kerber in a second. These are our conflicts, and this is the interventional team which is then performing the procedure in Mainz, where the main operator is Philipp Lutz. Now, our patient today is a 62-year-old female patient with progressive right heart failure. She's in New York Heart Class 3, reduced functional capacity, peripheral edema, shortness of breath, the typical signs of right heart failure. On the right side, you see her cardiovascular risk profile, some arterial hypertension. She's rather a small person with a BMI of 21. She was working until very recently, but now getting with the increased heart failure symptoms, much more limited in her daily life. Regarding her left ventricular ejection fraction, which is mildly reduced, she has a two-vessel coronary disease, and you will see some angiograms in a second with a very recent treatment of her right coronary artery in March. She is treated with an apheresis for an elevated LP small a and has some chronic obstructive pulmonary disease. She has some paroxysmal atrial fibrillation with some rhythm control. Here are the lab values. You see that she has a cardiorenal syndrome with a reduced GFR, but also a cardiohepatic syndrome with some elevated liver enzymes with the elevated gamma GT, for example, of 190 units per liter. When she is in sinus rhythm, she has an AV block first degree with a PQ time of 240 milliseconds. In terms of her medical therapy, she is on quite a dose of toracimide of 30 milligrams per day, and also her medication for the control of the blood pressure and the atrial fibrillation with candesartan and metoprolol. Here you do see the transthoracic echocardiogram with the mildly reduced ejection fraction. There is no significant mitral disease. She had this coronary angiogram for her coronary arteries performed, as I said, in March with a drug-eluting balloon PCI in this mid-segment of her right coronary artery. Of course, before the procedure of a tricuspid valve replacement, the team performed right heart catheterization, and you see that she has a mildly elevated pulmonary artery pressure, but with a very low pulmonary vascular resistance, which has a mild post-capillary pulmonary hypertension. This is the mitral valve, and I already told you that she has almost no mitral regurgitation, it's graded as 1, maximum of 2, and a very small aortic regurgitation. Now, looking already at the TE images of the tricuspid valve, you can see that she has a severe tricuspid regurgitation. It was graded as torrential, so grade 5 out of 5 grades. And when measured the vena contracta in a biplane fashion, it was measured as 22 millimeters on average. And with that, I'm going to hand over to you, Isabel, for in-depth analysis of the case.
Perfect. Thank you so much. Here I just copied a few pictures on the smart screen that I unfortunately not moving, but you know the smart screen does not do it. But we saw them in the beginning from Jörg. So here what we can see.
Sorry, can we have the smart screen up here on the main screen, please?
Yeah, that should be sufficient, right?
Wonderful, thank you.
Perfect. What we can see here is that we have a 3-leaflet tricuspid valve here. So what we can see is that the morphology of the valve is not quite complex, because what we need to look at is, we need to think about at the moment, it's still, if we think about replacement, we need to think about why is this patient not suitable for repair, or maybe not perfectly suitable for repair, because for repair we have better data and it's very safe. In this case, valve morphology itself is not very complex. It has 3 leaflets, so this looks fine. But what is quite severe is the coaptation gap of the valve. We can see it was measured at this time point in screening with around 8 millimeters, but what we can see is that the gap extends very much also in all of the 3 commissures. And this then leads, let me see if the next slide is loading up. This then results in, as we've already heard, torrential tricuspid regurgitation, and we can see that this regurgitation is not only in the anterior septal portion of the valve, but it is also very much in the posterior portion of the valve, so it's a very broad jet. So this case would be probably very tricky to be treated with repair in a very good fashion. So then on the next hand slide, we can see, because it's also very important, if we talk about replacement, our goal is basically with the EVOQUE valve to abolish TR. So what we do need to think about is RV function, and we have seen it in the moving pictures that Jörg has shown us, that this patient luckily has a very good radial ejection fraction of the right ventricle. The TAPC was measured with 23 millimeters. So herewith, this patient, hope so, should be fine, and there should be no cause or no concern of right ventricular afterload mismatch. And after having said these few words about the imaging in this particular valve morphology, I would like to sweep a bit for a few minutes into the specific needs for the imaging during the EVOQUE procedure, as you can see later on in the live case. Because it's a little different than what we're used to from tricuspid repair or tricuspid TEER procedures. We're using mainly during the EVOQUE implantation multiplanar reconstruction. Multiplanar reconstruction is basically a tool where we can derive 3 orthogonal planes, not only 2 as we're used with from the RV inflow-outflow view from TEER, from 1 3D volume. And this allows us to very accurately assess the position, the trajectory of the device, and also leaflet engagement for all of the 9 anchors. And this is very efficient for time manners, but also safe for the patient, because we don't need to rotate the probe up and down in the esophagus all the time, so we can keep it stable. And this is also very good for our frail TR patients. What we do is, from this RV inflow-outflow view that we are used to from TEER procedures, we do a 3D volume. We need to render it quite big and include also the aortic valve as a landmark. That's very important. And then using MPR, we go up here in this home view that we use during the procedure. In this home view, it's very important that we rotate it this way, that the aortic valve here is positioned at around 5 o'clock. And what we can see here now in the home view is one on-fast view, 3D from the tricuspid valve. On the left-hand side in blue, this corresponds to a short transgastric axis in TOE. So we have aortic valve at around 5. Then we have the septal portion of the leaflet of the tricuspid valve from 12 approximately until 5 or 4 o'clock, and then followed by anterior and posterior leaflet. And in the upper panel, we have 2 more boxes where we can see anterior, posterior dimension, and also septolateral dimensions of the valve. So 3 instead of 2 planes, which is of advantage. And then what we do 3 times during the procedure, and you will see it in the live case, is an MPR spin to check for leaflet engagement, if the leaflets are captured inside the valve. You can see here that the valve is already sitting inside the annulus, and you can see here very nicely that here these dots are the anchors of the valve. And what we do, we go into the blue box, rotate a little similar to CT, rotate the green line here in a clockwise fashion for each anchor, and then check each anchor here in the green box on the right-hand side if the anchor is and the leaflet is nicely falling over and into the valve and moving there quite nicely. And then one last word about wording, because we talk a lot about position and trajectory. These are 2 different things. Position is when we talk about where the system crosses the annular plane, and trajectory is actually where the system is pointing into the right ventricle. And with this few tricks and trips and also a few words on anatomy, I will give back to Jörg.
Yes, thank you very much, Isabel. It was a very interesting presentation. The question is it more perhaps atrial functional, or is it more ventricular functional? Do you have any idea about the...
Yeah, that's a very tricky question, because I think it's a little bit of both. I think it's mainly atrial, actually, because what we do see, and we saw it nicely in your moving pictures, is that the annular plane is quite labeled. So I think there is not much tethering, so I think it's not mainly ventricular.
So you have already answered one of the questions from the audience. Now, let's go back to the patient. Of course, there is always a heart team discussion about such patients. You have seen it's a rather young patient with 62 years of age. And of course, the team calculated the risk scores. You see here the Euro score 2 with about 7% mortality. The dry score has been calculated, came up with 4 points, which correlated to an 8% mortality for a surgical treatment of the tricuspid valve. We just have heard that due to the large coaptation size and the extension of the jet into the different coaptation sites, it might be not an optimal candidate for an edge-to-edge procedure. And maybe we want to go into a little bit into a discussion here.
Perfect. So thank you very much, Jörg, and thank you, Isabel, for those fantastic imaging explanations. We'll come to you during the case, if we may, and see how things evolve. Before we go to the lab, and they are ready for us, so we'll keep it reasonably brief because we can talk as the procedure is evolving. But I wanted to ask you, Volker, about the pathophysiology of the TR here. Is it all long-term sequelae of coronary artery disease, or is there something else going on, do you think?
No, I think it's, just as Isabel said, it's sort of a mixture. So I think the leading mechanism is atrial fibrillation-associated annular dilation. But she has coronary artery disease. We see some tethering of the septal leaflet, which might be related to it. And also the RV is, I think, mildly dilated in the mid-portion, which is also probably a result of her coronary artery disease.
And we also saw the right heart cath data, which weren't particularly impressive. But is a right heart cath mandatory in the workup for all of these patients?
I would completely say so, especially if we're planning for valve replacement. I think we have to have all these data.
And I need to check with Isabel that she approves that, because you can tell us about the hemodynamics using echo, no?
No, definitely not. I'm 100% with you. Definitely invasive hemodynamics, yeah.
Okay. And finally, Raj, in a world without EVOQUE, if you can imagine such a world, would this patient be a candidate for T-TIR in your hands?
I think I would be reluctant. This is torrential TR, and as Isabel pointed out, with coaptation gaps that extend everywhere. So I don't think we're going to get a good result with TR. And I think the biggest problem with TR is not only that it is an at times in bad anatomy is not effective, but then it actually burns the bridge for a more definitive treatment. And I think that's why we have to be really careful in adjudicating these patients.
Okay, perfect. Well, let's not keep Philippe waiting any longer. He's had a long, difficult day doing several live cases, so I'm sure he's keen to get this procedure done and in the bag. So let's transition now to Mainz, and I hope, Philippe, you can hear the conversation we've been having, and if we can link directly to you and the team in the lab.
Hello and welcome everyone here with us in Mainz. We very much enjoyed your discussion. We think that you perfectly set the scene for what you will see in the next 30 minutes, which is an EVOQUE implantation in this lady, and you heard all the details about the lady, the decision making, but also the various specifics in terms of imaging, which is required and extremely helpful for such an implantation. What we've done so far, obviously we gained access, this femoral venous access, and then we advanced the system already and positioned it into the RV. If you could have the fluoroscopy and the echo live on screen, please. So what I would like to draw your attention to on fluoroscopy, you see obviously the wire, then you see the tip of the catheter, and then you see a bit of a distance between the tip and the capsule, and this is the so-called capsule gap. And that structure also corresponds to something you will see on echo. Teresa puts the marker now around this capsule gap. And that capsule gap is the first very important step of the procedure, because that one helps us to get the height of the system right. The system or the procedure you will see is pretty straightforward. There is no point in between to rush. There is no moment of hemodynamic instability or anything like that. The only thing which is important, there's only one way, and this is forward. You cannot go back during any step of the procedure. And that's why it is important to remove the capsule and allow the anchors to flip and unfold at the perfect height. Not too high, not too low. If you're too low, and this is also specific for the tricuspid valve, then you might struggle to get up again. If you're too high, then it might be difficult to get underneath the leaflets again. So that's something we have to make sure to get it right. Maybe we can have echo on enlarge, please on screen. And then the other thing, and that's something we've done already, we try to make sure that we have the system aligned really orthogonal to the tricuspid annular plane. On the left, you see a view looking at anterior and posterior in green, and the system is pretty much 90 degrees to the tricuspid plane. And then on the upper right, this is a view looking at septal as opposed to lateral. Again, pretty much 90 degrees to the tricuspid annular plane. And at that point in time, we can then retract the capsule further and allow the anchors to start flipping. Any questions?
Volker, any questions for the team in Mainz?
No, I think this was an excellent presentation, and I mean, as Philip excellently said, I mean, this is the point where you still can return. Now, the next step, once the anchors are released, you have to deploy the valve, and so it's very important to be sure about the alignment of the valve and this, in particular the height.
Yeah, so it's very customary to do what is called a timeout and to make sure that you have enough reserve left. So you'll see how much of knobs you have utilized and how much of clockwise or clockwise rotation you have used. And once the team agrees, then you sort of move forward.
Yeah, very important, Raj. We did that actually. We do have a bit of still room with all the knobs and a flex we can apply. So what I do now is I retract further the capsule gap. You can watch that both on echo and on fluoroscopy. Normally what it does, it changes the height of the valve a little bit, or of the system. So we keep on watching closely. We want the anchors to flip Yeah, not too low, but roughly at the height of the leaflet coaptation in systole. What we realize now is that the system went slightly up into the right atrium. So we observe that and see whether we can apply a little bit of depth. What you can do with the system, obviously, you can change the height. Going further in is a little bit easier than increasing height. Yeah, I think we can continue. That's okay. Okay, so you can see now on fluoroscopy and on echo that the anchors start to come out. We also see that by doing that and retracting the capsule, we moved a little bit up. What we then can do is either retract the wire a little bit, which we did already, or, and this is a feature of the system at the very end, we have a specific handle, and if that is turned, the overall system will travel ventricular. So we do that now. Tobias will apply a couple of turns at the back, and we see on fluoroscopy and also on echo whether that will bring us a little bit more into the ventricle. And then we have to correct because the trajectory changed a little bit. So we take off some flex, and that's pretty much what that procedure is all about. Making sure that in all planes you have a perfect trajectory, checking the height, and then just moving slowly but steadily forward. Okay? So what do you think about height?
I think you're good, but as you flip, you might lose some. So I think often, as we are releasing, we tend to give a little bit of depth so that you can sort of stay there, or at least not go above the systolic coaptation.
Yeah, we did exactly as you said. We added a bit of depth.
That's good. Jörg, do you have a few comments about the learning curve for these procedures? I mean, clearly familiarity with the right heart and tricuspid tear is important.
Okay. Well, for sure, the knowledge about the morphology is important, and it's especially sometimes very tricky for the imager to get all those planes always so well displayed as it's going to be shown here in this case. There's a learning curve, so for both the interventionalists and also the imagers, which we should recognize. But overall, the procedure is so well controlled that the learning curve is rather short, I would say.
Maybe we go for a second into an explain view and see what we see, and then maybe readjust the MPR.
Yeah, of course.
Okay.
How often do you use ice, especially at this stage when you're trying to assess, the leaflet capture or readiness for capture in your cases?
Okay.
The question was about ice. Do you use ice at all?
We don't use ice for these procedures. It might be helpful. I personally can't comment because I don't have the experience. But maybe Raj can comment.
Yeah, we'll come back to that question in a moment. Just let us know what you're looking at, Philippe, and what are the key parameters that you're assessing.
Yeah, so most of us are probably more familiar with that sort of view, an X-plane view, left a bicommissural view, and then the corresponding long axis view on the right. But this one is more to help us to get another MPR. So from this view, Teresa will in a second reconstruct again the MPR, and then we double check everything.
Okay.
The next step will be to flip the anchors, and then we have to see whether all the leaflets are engaged on the anchors. But again, we want to make sure that the height is correct, that we have the perfect trajectory, that we're not tilting towards one side or the other. We can correct for everything with the 3 degrees of freedom of the system, and it's really a procedure where you go a couple of steps forward, check, readjust, 2 steps forward, check, readjust. There's no pacing needed or anything like that. There isn't any point during the procedure where you should be worried about hemodynamic instability. I think you can see that the leaflets, they're interacting already a little bit with the anchors. I think the height is okay. But we will take the time, another minute or so, get the perfect MPR, and then we do the flip.
Tell us a bit more about what Philip means by the perfect MPR, Isabel.
Yeah, that's a very good question. Actually, I think most of the time the visibility gets a little better the more you open the valve. And so in this stage you are in, it's quite normal to don't see these anchor dots perfectly well. And actually, the good thing is that in contrast to TEER, where you need to be very, very sure that you grasp exactly this leaflet with exactly this device, you can be with the anchors, and we will see it later on in the spin, you can, if you're not sure about one, you can always come back to it, and this is very smoothly. And I think actually they are doing a very, very good job with the MPR already, and I think it will be even better visible if the inflation is further on. I'm pretty optimistic in the sun. This looks very promising already.
The only difference to TEER is that you can go one step forward and 2 steps backwards.
Yeah, that's
whereas
true.
You can't do that here.
That's very true.
Jörg, I think you had an additional comment.
Yeah, we have one more question. Perhaps, Raj, you can answer this best. This valve is coming in 3 different sizes, 44, 48, and 52 millimeters. What kind of workup do we need to do, because we haven't spent any minute on that, to decide on the valve size?
Yeah. So, this CT is so important, right? And I think because you're going to assess everything, the leaflets, the RV, the papillary muscles, the annulus size, all of those things. And not only that, you'll actually even simulate the procedure. So, and that will tell you how much primary flex you're going to use, how much secondary flex you're going to use. So I think it's an absolutely critical part of the assessment.
It's CT-based sizing, and then do we need echo for sizing as well, or what do you look at echo?
So, we learned our lessons from 3 years ago. I think we didn't realize the shifts that can occur in the size of the annulus in patients. And, so it is customary now, after having learned a lesson, that on the day of the procedure, we will reassess the size of the annulus and see if the perimeter sort of corresponds with what we actually had on CT. So I think it is important to reconfirm on the day of the procedure.
And does that variation relate to fluid loading, Raj?
That's correct. And I think from there came the idea of what is called prehabbing, and putting these patients in the hospital for a day or so, or a couple days actually, diuresing them so that you're not surprised when you actually go to the cath lab.
And we've learned in TEER practice as well that similar relative dehydration of the patient allows the annular gap to be narrower. Yeah. So I know there's some questions queuing up. So just hold the questions. Philippe, do you want to bring us up to date?
Yes, so we did the full flip, as you can see on fluoroscopy. And then we can have echo enlarged again. So Teresa will prepare again the perfect MPR. And then we are ready to do the first spin. And spin means that we go through all the 9 anchors and try to appreciate whether and how the leaflets interacting with these anchors. Obviously we want to have all anchors, or we want to have all the leaflets on anchors. You might be able to miss out one anchor, but obviously we try not to miss any.
Okay.
Are you ready?
Should we start with the spin now?
Yes, please.
Okay. So we look at the blue box, and you see the green line is cutting the anchor at 3 o'clock. Corresponding the anchor you can see in the green box on the right side. And here we see the leaflet above the anchor. And so we check each anchor and make sure there's in the right position. So we rotating clockwise, and the anchor at 5 o'clock it's captured. I continue. The next anchor is in the shadow, but I think it's okay. We check it. And the anchor at 8 o'clock is captured as well. And the anchor at 10 o'clock, it's captured as well. Now we are at 11 o'clock, it's captured. And the septal one at 1 o'clock, it's very small, I think it's captured as well.
Maybe you can stop here, go back to that anchor, and show in the green again with the cursor a little bit where the leaflet is and what we're looking at. Because if you feel that you're not particularly familiar with these views, then
you see
I
the
could
anchor
perfectly
at
understand.
1 o'clock here on the right side in the green box, and the leaflet just above the anchor, up and down. Yeah. What do you think?
Is that the commissioner? No.
Okay.
Is that?
Yes?
I think the commissioner is at 2 o'clock. Right here.
Okay, let's go back to the posterior leaflet. I thought that was more difficult to appreciate.
Okay, which one? At 9 o'clock?
Yeah.
Okay.
That one is in. Yeah, that one is fine. What we can also do as an additional assessment is to go transgastric. I mean, we have good views, but as always, and this is why I'm not sure whether you need eyes for these procedures. You can make the most out of TEE. There's so many possibilities, and even if you start off in thinking that imaging is difficult, there will be always a window which is helpful. And let's see what we'll see on transgastric.
Let's just find, while we're finding the transgastric optimal view, Raj, do you use ICE in Los Angeles?
I think very rarely, maybe less than 5% of the times.
So you'd agree that TOE generally provides all that you need?
Absolutely.
Okay.
And especially for EVOQUE, actually, ICE has not the best MPR resolution, and that's exactly what you need for the EVOQUE, for the anchor spin. So especially actually for the EVOQUE implantation, ICE is, I would say, less useful than maybe for TEER, because sometimes for TEER, visualization of the leaflet grasping is more important, but for the anchor spin, nowadays, the technique we have is in MPR, not perfect with ICE yet.
Okay. So, Volker, I think you were holding a question. Is now a good moment?
I just wanted to come back to Jörg's question about the TEE in screening, and I think, I mean, there are situations like if you have a primary component of your TR, like a flail with a large width, this can be something that can be difficult for EVOQUE. And then also we have not talked about pacemaker leads. If you have pacemaker leads in, it's not a problem as such for EVOQUE, but there are situations with pacemaker leads you have to be aware of where this can be problematic because you cannot get underneath the leaflet.
Okay, thanks very much for those comments.
Teresa?
Yeah.
Yeah?
What do you think?
We're back with you, Philippe.
So maybe let's have another look on the posterior leaflet here on transgastric. That was the one which was more difficult to appreciate on MPR. Yeah, we can do it. And Teresa will guide us through what we are seeing there.
Okay. Okay, so you can see the leaflet, the anchor at 10 o'clock in the transgastric view, and it's corresponding to the anchor on the upper anchor. And you see the leaflet is above, it's captured. So I swip to the next one at 12 o'clock, where you can see here the upper anchor and the leaflet is captured. Yeah.
And here sometimes it can be misleading because you see a structure going on top of the anchor and you see a structure running behind
it's the cord
the anchor, and
of
that's
the papillary
cord.
muscle.
Exactly.
It's the cord here. The papillary muscle is at 1 o'clock. Here.
Okay. Let's go back to MPR, then retract further the capsule. Thereby we will get a tiny bit of more flip, but also a bit of expansion of the ventricular part of the valve.
So it's clear, Isabel, that very stepwise progression with careful imaging guidance and concordance at each step is important, yeah?
Definitely, yes. And so at the beginning, it's very important that all in the cath lab know what we're looking at. They need to know where is the aortic valve. You need to know before the valve is in, because then, as you can see, it can get a little shadowy. You need to know where are the commissures. You need to be very sure of the anatomy of the valve, that all in the operating room are on the same page with that. And then, which Philip already said, the beauty of the procedure is that it's very smooth, right? So you have all the time to talk and interact.
And the imaging specialist is in charge, correct?
We'll ask Philip that one.
So I missed that one?
Okay. No, we were just kidding, Philip.
So
Okay.
I think we saw that.
Okay, we have the full flip now, and now we do another spin.
Okay.
Just
so
while
we
we're
start
doing
with
this.
the anchor at 4 o'clock. You look at the green box on the right side. The anchor is under the leaflet. I continue at 5 o'clock. It's captured. Next one in the shadow. Okay, but I think leaflet is over. Okay, we are at 6 o'clock. We are 8 o'clock. It's captured. The posterior one. 9 o'clock, it's captured. 11 o'clock, perfect, captured. 12 o'clock, captured as well. 1 o'clock.
Okay.
It's a commissure.
And at that point,
then,
yeah. Did we go through all of them? Yeah.
yeah.
Okay, good.
Okay, back to home view.
So obviously we could do tilting maneuvers. We could make sure that we get one anchor underneath the leaflet if one is up too high. But here you see us doing pretty much nothing. But this is also due to the fact that we have a good trajectory and we see the leaflets on. So we continue.
You're right, and I think this stems from the fact that your starting point was excellent. You were in the middle of the valve, your trajectory was good, and your position was good.
So you're suggesting, Raj, that we didn't see it on camera, but that setup is key to the success of the whole procedure.
Yes, because otherwise you end up doing too many maneuvers, and that just complicates things.
Can I add something? So I think the initial position is very crucial. Is there any role? Because in the past we implanted a transcatheter tricuspid valve, but by tracing the right coronary artery that we can see there, is there any role in making an angio of the right coronary artery and to start using that as initial positioning?
Good.
Because the right coronary artery is there in the sulcus, so why is not there? It's there.
It's an interesting
look
thought.
right.
I think the argument back would be the echo is telling us all that we need, but it's an interesting thought, isn't it, Volker?
I'm just telling
the
the
anatomical
starting
landmark.
position. And the starting, because with a navigate, it was for jugular, actually, we use as a reference the right coronary artery.
Slightly differently?
No, I mean, I would completely agree. It's great as an orientation, but I think echo is much more exact. And because you have variation in the anatomy of the tricuspid valve, and we saw that we need this. But it's a great point for the initial orientation.
Jörg.
We started initially 4 years ago with putting a wire into the right coronary artery, but learned that at the end it didn't help us so much that we're going to get rid of that and just rely on the echo.
So Philip has completed the ventricular expansion phase of the valve, right?
Let's go to another X-plane view. It's just something we are a little bit more familiar with, and then I think
At
we
the
are good to
posterior
go.
one.
Philip, what are you looking at right now? What is now the question?
Just to reconfirm that everything is as we thought and seen 3 minutes ago. That's also some part of the procedure, right? That you keep on confirming that while further flipping and while further expanding, that what you've seen and assessed and assured 3 minutes ago is still valid and true. Because obviously when you have the valve expanding a little bit and when you have the anchors flipping, you also change slightly the position of the valve in the heart. And it's really tiny things But this will be pretty much the last time we check anything, and then we release.
Because what you really also see very nicely is the relation of the anchor tips to the hinge point of the leaflets, so that the valve is really, in terms of the positioning, really high in the tricuspid valve.
Yeah, I guess this is important because there's not too much we can do now other than correcting a little bit for height. So we see the anchors pretty much on the hinge point. The valve normally will come up a little bit, but we certainly don't want it to be too low. So that would be the final decision to make now, whether we try to, or whether we remove a little bit of depth, meaning trying to move the valve further up. But it seems, and this is, we will decide in 30 seconds, bear with us, whether the anchors are really at the hinge point. If they are, then we keep it the way it is.
Space.
Yeah. I think we have a tiny bit of distance to the hinge point, but this is maybe 1 millimeter, and then, yeah, this is academic.
I think we're very good.
Okay, then.
So
everyone happy to really?
Are you happy with the posterior as well? Yeah, there's a little distance.
Bernard?
Philippe, could we see your hands when you release the valve, just so we see what the delivery system is doing?
Okay, I go back to the MPR.
Okay, so before we turned the white knob, which allows the outer capsule and the flipping of the anchors and the ventricular part of expansion, and now we move towards the blue knob, which we turn, and that will cause the atrial portion to expand. Okay. Again, we do that slowly. We double check on echo. Yeah.
Release. We're almost releasing. Oh, they're releasing. Almost. Yeah.
Okay, we'll release. Okay, we will release now. Okay, the valve is released.
You can all breathe now.
I mean, it's moving throughout the cardiac cycle. I'm not sure whether you stopped breathing, we kept on breathing, but only a little bit.
But it's also good to look at the ECG, which is still the normal sinus rhythm, so we don't have any significant AV block.
So it's you can see the height was perfect actually, good height, and also it's also customary to be ready to pace. So you would have alligator clip and some grounding all done on the other side of the groin, just in case if you need to pace. And so, Philippe, I saw that you pushed the wire so that you could get the nose cone out as you were. Yeah, I think that's important.
Yeah, pretty much all the steps we did before, we now have to do in the opposite
direction.
Exactly. And we do have still the wire in place, but normally I'd like, before we do the full assessment, I'd like to get out of the valve with the delivery system and then look at everything more closely, as we've done now. We go even out a little bit further. But maybe Teresa could tell us a little bit whether she's happy.
Okay.
We'll just have a little internal discussion, Philippe, while you get some echo data, and then we'll come back to you just in a minute or so, if that's okay.
Yeah, perfect.
So, Isabel, firstly, are there specific recap messages in terms of the imaging that we saw very carefully executed here? Just a quick summary for this audience, please.
So, as we've already said, it's a little different than from the tricuspid TEER procedures. What we are really doing in the beginning, which is very important, and Philip pointed it out nicely, we did not see it. The position in the beginning is that what we need to look at, and this is very, very tiny maneuvers, and the echo, which is the beauty of the procedure, the beauty of MPR, is that you can just stay in your MPR if you ran it at once, and then you can tiny movements, just check the position, the trajectory. And then later on, when you get the capsule gap and then you're opening up the valve, then you can do the spin. And as you've seen with the spin, you have your time, and it's normally completely fine actually to be visualized. And with a short learning curve, I think this is, from an imaging side of view, quite an, let's not say easy, but quite a comfortable procedure.
That's perfect, thank you. And then Raj, I wanted to talk a little bit about the anticoagulation of these patients. I mean, obviously they're frequently in atrial fibrillation, persistent or paroxysmal, but let's just hypothesize a sinus rhythm patient. What's the anticoagulation plan?
Yeah, I mean, you have to give anticoagulation for at least 6 months, and, while, during CTs, we've observed some leaflet thickening. It doesn't seem to be causing any major issues, and the gradients have actually traditionally stayed pretty low. So I would say that anticoagulation works. You can use DOACs, you can use warfarin, and if patient can tolerate, I would at least make an argument. I would make an argument that to even continue beyond 6 months.
I mean, clearly the data are going to emerge
till we learn more
in the years to come. Absolutely.
Yeah.
And Volker, what about follow-up of these patients? I mean, beyond the normal follow-up, what are the particular points of reference?
Well, I think first of all, I mean, now the procedure is over, but these are patients who need to have a closer look at in an intensive care unit setting. I mean, we made the experience that recovery takes a little bit longer than we're used to with TEER procedures, so you have to account for that. I mean, bleeding risk is higher in these patients. Not particularly with the groin, but you have also to be aware of bleeding in the gastrointestinal bleeding. These patients have a higher risk. And then for follow-up, I mean, it's mostly related to the risk of thrombosis, where you have to have a close look at the gradient.
Do we need to think about CT to look at leaflet thickening and HALT and so forth? Do we need to learn from the TAVI experience?
I mean, we don't do it so far in our experience, but I mean, as soon as you see the gradient moving, I think it's something in this early phase of the therapy that you should do.
Yeah, okay. And then Jörg, if you can, could you give us an overview on the development of this valve? How many have been done? What are the plans for the next phase of evolution?
Well, I think worldwide, including all the compassionate use experiences, the study TRISCEND 1 and TRISCEND 2, we're coming close to, I think, to 1,000 patients which have been treated approximately. I think we're all awaiting very eagerly the final results of the TRISCEND 2 trial, which are hopefully presented later this year. And then I guess there are many additional questions coming up. A number of patients are being screened out due to the valve sizes. We do see patients who have significantly larger annuli, which cannot be treated with the EVOQUE current system. But with the addition of a larger valve, which is probably also coming out very soon, we might also be able to tackle these patients.
Okay, so a lot to look forward to. Raj?
Yeah, we do have access to a 56 millimeter valve in what is called continued access. So I think that'll help significantly. And I think one of the things that was mentioned earlier is 1/3 of these patients actually have pacemaker leads in place. So, it works remarkably well in most cases, this particular device with concomitant pacemakers.
So, Philip, we're coming back to you for a final summary and a review of these beautiful post-procedural images.
Yeah. Okay, maybe you've seen what we did with the groin, just a stitch. It's a 28 French system, but it's venous, and a suture of set did the job. And then on final echo, please bring that up on screen. You see that there is laminar flow, no gradient, no paravalvular, and also no transvalvular tricuspid regurg. And that sometimes can be seen an acute slight depression of RV function, echo up again. But here I would say that RV function hasn't changed dramatically. It was good to start with, but the RV is still doing good.
Wonderful. Well, Philippe, once more, we pay tribute to you and the Mainz team. You've performed admirably in the main arena and the Théâtre Bleu here this evening. A very beautiful demonstration of stepwise, slow, deliberate amalgamation of the echo imaging and taking it step by step towards a very successful, complete procedure. So a round of applause, please, from everybody here. So 90 minutes ago, we set out with the objective of completing 2 live cases, which I think you will agree were both done extremely skillfully, demonstrating these innovations in the aortic and the tricuspid valve space. We've also had 2 great lectures outlining experience from around the world, and we've had some very spirited discussion around the challenges associated with these evolving technologies. So thank you very much for joining us here in Théâtre Bleu. We wish you a great evening in Paris, and I hope you enjoy the rest of EuroPCR.